Okay, so I now request Anand sir. It's a wonderful topic. I am eagerly waiting to listen for that.
Yeah. So, Peter Ratnan UV Fellowship, how I would excel as a program director, and there can be many takes to this. So, first thing is the selection, picking the right cherries. So, there's always this thing when you pick, you need to look at two things. We tend to look at the scholastic aspects, the aptitude, but I think it's also important to judge to some extent attitude. So, while aptitude is king, attitude is everything. And with the aptitude, that is more easily judged. When you have a Surfeter Fellows, we have an entrance exam. I remember 20 years back, there were hardly any fellows coming for retina, but now a huge number of people are coming and we've flooded the applications. If you have that as a cluster, you can do an entrance exam in which it's important equally to look at comprehensive opthal, core knowledge, as well as specialty knowledge, because you need people to be rounded figures. So core knowledge and applied knowledge together should be assessed in your examination format if you're having it. And it's best to do it in an objective way with MCQs, but you can also have reasoning kind of questions. And when you have that kind of a exam format, you need to have a must-know category, a good to know category, and then the great to know category. And it's ideal when you're doing this to have a weighted scoring where there is more negative marking for those who miss out on the must know. So, you don't want somebody to know fantastic trivia but not know the essentials. Then also it's important to look at the background pedigree, where they've done the undergraduation, where they've done the post-graduation from, because it takes a lot of hard work to get into a really reputed institution to do that. And undergraduation, 5 years of MBBS is a tough course. So you cannot, fool that with that. So, somebody who's come through that and has done well in his undergraduation, you're looking at good material. Then also the awards, presentations, publications that they've managed to do in their undergraduation, post-graduation, I think that also has weightage. And in your Viva, which you are conducting, spotters are good for testing core knowledge, but I think it's also important to throw them clinical situations to see how they approach problems. Is it just a, one fit formula, or are they thinking? So all that is there from the aptitude point. Then attitude. This is not that easy to judge in a 10-minute interview. You need to see check if the patient is earnest, sincere. I mean, sorry, the candidate is earnest, sincere, is humble. We talked about that question of kitna cutting and all that. You want to know whether people are showboats, and it's a very fine line of difference between somebody who's aggressive and somebody who's actually passionate. So you need to be able to nose that out, and that comes with experience. And it's also important to judge whether that person sitting in front of you has the capacity to be part of a team. I think that's very important, especially in the setups that we work in. And also whether that person has clarity of purpose. Somebody spoke about, Dr. Shobit said about, what are you going to do 4 years, 5 years from now? I mean, whether some person has some sort of a roadmap ahead of him, or is it just to get a label of a degree? So that also needs to be looked at. And if it is possible, if you don't have a large number of candidates, it's also good if the candidates interface with other consultants. This is what I've started doing in my setup right now, that the candidate goes and sees the other consultants, and then you take your viewpoints of your colleagues also. So, a junior colleague may have picked up something which you might have missed in 10 minutes. Another ideal thing is to have an observation period, a week or so, because people can be very charming in 10 minutes of interview, but you can't really always do that over a week's time or a 2-week period. So a good observation period would also help, but then you have to see whether it's feasible in your specific setup. Then a defined program is always a refined program. You need to put out, it's ideal if you can put out a well laid out curriculum, defined postings, rotations, so that candidate knows, going forwards, I will have, this is when I will be doing this, and they can focus or they're reading, or they are at least assured that they will be trained in these areas, UVA, ROP, oncology, perhaps electrophysiology. The learning objectives ideal if that is specified at different stages of fellowship. And we usually look at 0 to 3 months, 3 to 6, 6 to 12, 12 to 18, and 18 to 24. And we've actually we have this in our logbook also for the fellows, where it's actually measured out and laid out right there, where not only is the first month and second month, third month, all the aspects that will be looked at is there, but also why it is being done is also spelled out. I think a lot of effort went into putting this logbook out. There's a huge number of people who did that, credit to them. And the purpose, say for the second month, angiography posting, 16th 30th month, 16th 30th of the second month, ultrasound posting. Then third month you have UVA, fourth month OPD postings. and the purpose is also laid out. And this is why, pertaining to your question earlier as to whether you can, quick jumpstart somebody on a surgical training, they will miss out on all these programs. So when you reach a 6 month, you know that everybody is benchmarked to that particular level uh, in terms of grounding. And then the surgical training then starts warming up from that point onwards. And then you start with small steps and then go on beyond. And again, expectations are laid out during the fellowship program, what they should do, the screening camps, the presentations in meetings, in grand rounds, taking part in CMEs, etc. And also the criteria on which candidates are continually evaluated is also laid down, so that they also need to know that these are things which will also be looked at apart from scholastic ability. So punctuality, taking responsibility to work, keenness, teamwork, etc., clinical, surgical, and academic skills also. So this is something I like to do. It's always being done. We put out the fellows posting and we divide all the things and then put all the fellows there, so they know. Not just do they know, the consultant also knows where the fellows are, as well as the staff, the paramedical staff knows where they are posted, and so there's a very clean organization of work from that point of view. Then also laid out is, not only is the specifics of the doing of procedures also laid out, but it's also, why things are being done is also laid out, so that there is a standard benchmarking across. And so are the duties also. Now, very importantly is the approach that a candidate needs to take. So to reading, basically medical and surgical, we'd like to tell them that, they need to be strongly grounded in the basics in the first 6 months is what we generally tell them. Then intermediate, 6 to maybe 12 months, then advanced training. But then the reading also, as I keep telling my fellows, needs to be two-tracked. One is your theory, which needs to go continuously in the background in an organized way like this, basic, intermediate, advanced, but also importantly case-based. So if you see a case, you need to read up about that case, and that is very critical. So two-track kind of reading. One is the regular scholastic reading, but on the side, cases that you see, you need to read up and come back to me the next day and tell me about that. So to working up a case, methodical approach needs to be worked up. I think Dr. Shobit also said, don't just jump into the diagnosis, go step by step, history, clinical exam, etc., and specify a plan. You'll see this theme recurring in my presentation, specifying a plan. We need to know what the candidate is thinking and commit to that. So this will keep coming. To surgery also, importantly, we've already touched upon this, surgical workup, meticulous charting, and specifying a surgical plan too. The approach to difficult clinical situations, it's important for them, not everything will have a clear-cut answer, especially in retina. So they need to come up with a logical sequence of differentials, common and then rare. Very often you find very enthusiastic candidates coming up with some fantastic diagnosis they've heard of in a conference or seen in a grand rounds, and then just go with that one particular diagnosis. They may be completely missing the boat. So a logical sequence needs to be followed, and that needs to be emphasized through the training program. And finally, most important, to difficult patients. How do you approach difficult patients? So the diagnosis may be simple, but the patient may be difficult. So it's important for them also to focus on soft skills. And this again, I will come back to later. Communication, compassion, patience, empathy. An important thing is to win the patient, So you may or may not be able to help them with the disease. Disease may have run its course, there's not much we can do, but you need to, the patient needs to believe in you. Then documentation. I think this is very critical, and especially in fast-paced, heavy volume clinics, documentation is critical. I think history, taking systemic, family, ocular, a focused history taking, that is an art. I think that is something which needs to be gleaned from the mentors. So that is critical, and that comes with experience and time and with training. Detailed clinical exam notes, this is one part that need not be compromised. This is not something that there needs to be any shortcut to. So putting what you see in a very meticulous and very accurate manner has to be focused on. Diagrams. I know a lot of us now have moved to electronic medical records, where it's becoming increasingly little difficult to, do exactly what we were doing as our fellows, doing handwritten diagrams. But then that effort should always be there, and that emphasis should be there from a program lead to the fellows. Reporting of investigations, I think that is also something which needs to be done. It tends to get pushed back. They just write the diagnosis, but a logical sequence is how they arrived at the diagnosis, looking at the different aspects of, say, a fluorescein angiogram or B-scan needs to be specified. And then this is what I keep talking about, specify the management plan. Let them commit. Tell them to commit to a plan. What would you do? How will you manage this case? What is your surgery choice? Prepares the mindset for the candidate for post-fellowship an independent position. Writing clear prescriptions is important. I mean, very often, now of course with electronic records, things come automated and a lot of things the system does for you. But going back, when they leave, they will not always have EMR with them. So you need to write the dose, exact specification, duration, everything. Surgical notes need to be very detailed, intra-op diagram. This is very important, not just from a training point of view, but honing them so that from a medico-legal point of view later, all the complications intra-op needs to be recorded very carefully. Post-op instructions should be mentioned extremely carefully. So all these things are very critical to the point of training. And this is how we encourage fellows to, document in our logbooks. We have specific pages for lasers, for intra-op outpatients, etc. And proficiency with diagnostic, I think this is very important. It's part of the skill matrix. They need to know how to not just interpret, but also do. When they go out, I keep telling them, here you have technicians, but when you go out, you'll have to do everything yourself. So you need to get that hands-on understanding. And again, people talked about knowing the basics of your laser machine, your fluorescent machine. So you need to actually do that. It's a hands-on experience, very important. And then of course going forward, and you're not just training them to be technicians, but you need them to be reporting very accurately, and it needs to be focused ordering. So all our fellows at Chennai, all of them have the postings, and they do a significant amount of investigation work themselves. So photography, B scans, and OCT. So in proficiency with intervention, needless to say, that's critical. We have this model eye where the fellows at the beginning start about 10 to a dozen model eyes have to be done first, and then the first 2 dozen cases are very strongly mentored, and they're followed up by the consultant, and only then can they go on to semi-independent and independent lasers. Same thing with the injections. The pre-injection protocol needs to be very strongly grounded in, and and the models need to be seen, and then they go in from injections, from the lower end injections, and then slowly graduate on to the higher end injections. And all this is done by, very important is the culture. The department DNA needs to be set in terms of discipline, attendance, punctuality, a strong dress code, adhering to break times. The work ethic needs to be strongly honed in. The sharing of work. There is no such thing as this is my work, this is your work. Fellows need to understand that there has to be a lot of sharing of work, and attitude to colleagues, staff, patients. You need to ensure as a leader that the work needs to be a fun place too. So there's always a saying that if the work is fun, then you're not really working every day. So that kind of a light atmosphere, but in the background of having a strong discipline setup too. And then importantly, that's when you transition from a department to a team, and the boss, chief, yourself as to a leader. So a leader needs to walk the talk, practice what one preaches, and the team needs to see their leader, see cases with them, be a role model, quality documentation, meticulous exam, ensure work efficiency, and remember that the buck needs to stop with you, and you need to take that call too. Mentoring is something which is critical, and I think different institutes have different programs and different ways of doing it. It's also dependent on whether that particular institution has an appointment-based system or walk-ins. It's more easy to do a strict mentoring program when you have an appointment-based system, unlike ours. But we try to do the same to some extent. We have minimum quant of cases that a fellow sees, which is seen by the consultant in terms of finals. And it happens the way we've designed ours is like the surgical fellows are tied up to that surgeon, and they generally follow them pre and post-op. So learning objectives need to be specified, as I mentioned earlier also, at the beginning of a month. So the fellow needs to know, this is what I need to learn in this month. And then you keep checking that status evaluation. And this proficiency is also in not just surgical, but medical retina also, as well as diagnostics and lasers and injections. And the objectives are then assessed by the consultant every weekly and at month end, and then a feedback is conducted by the head, and then we check on the fellow's status and his progress. Communication is critical. I mean, the head, I think, needs to be approachable, accessible. Transparency needs to be there in whatever decision is taken for the fellow. Clarity of role is also critical. Regular team meetings, individually with fellows, consultants, and the whole department, as well as one-on-one is also important. And then issues will always be there that needs to be resolved at the earliest. As I mentioned earlier, fellows, apart from scholastic, you need to look at soft skills too. Finally, encouraging excellence in academics, didactic, and classes. It's ideal to have short, focused topics rather than very wide, 1.5 hour topics. 30 minutes, I think, is ideal with 15-20 minutes of interaction. And all fellows That's one thing we emphasize. They need to be prepared. Case presentations, journal clubs are the way, and we have a schedule right through going on. And publication is also something that we are focusing also on. Case reports, case series, retrospective short studies to begin with, and then moving on to the larger prospective studies is vital and useful if a fellow attends at least one research methodology workshop and is schooled in research methodology training through that period, and takes up at least one research project per year. Presentations also at good meets like AIOS, VRC, RetNet, DRF, RIC, and Asia Pacific meets, and also encouraging fellows to take up benchmarking exams. And we are happy to report that in our 4.5 years, some of our fellows have passed all these exams, FACO, ICO, and FRCS. Surgical has also been talked about by Dr. Guru Prasad. We encourage this obvious graded learning kind with the surgical steps and then going forwards. Wet lab was not really possible during the COVID period, but now we are trying to revive that. Madurai and Coimbatore have a surgical simulator. Surgical recordings is what we are doing now a lot, and then reviewing them. And also in our center, fortunately, we have the digital ingenuity system, DAVS, as well as the analog, so fellows get exposure to both kinds of this thing. Clinically, again, as I mentioned, apart from the examination and the diagnostics, we try to focus on, ask fellows, what is the case of the day? What interesting case? It just doesn't have to be a case from diagnostic point, but some interesting finding, some interesting angiographic depiction, something interesting on the OCT. I keep telling them, if you have not learned anything that particular day in your fellowship is wasted. So you need to be, your radar needs to be tuned to that. When you leave that department that day, you should have taken something from the department. An important thing is archiving challenging cases for presentations and grand rounds. They need to constantly be on the toes. And then importantly, working and following my cases and research projects also. Innovations, this morning we had a series of excellent talks in that out of the apple tree. I'm very happy that AIOS is pursuing this. It encourages out of the box thinking, and we're seeing most of the presentations were from younger students, and many of them were fellows. So that helps them with bringing up creative solutions. Most of them are about instruments, techniques, exams, lasers, or surgical, but also importantly in practice changes, and we saw a lot of that happening during the COVID period. Also tech adaptations. I think the younger generation is positioned to lead that. Finally, creating leaders. Sublet responsibility. Don't take everything as a leader upon yourself. So create a leadership ladder. Sublet responsibility, oversee progress, keep an eye on the process though, avoid micromanaging, allow innovation, but also importantly just focus on results. So as a leader, having spent a lot of time, you may have certain mindsets. It's important to be flexible with your mindset. All this helps generate efficiency and a sense of ownership. Also handling discord and agreement, I think it's important to show that there is fair play in the system, and you need to be amicable to solutions. Attention to students, fellows, and colleagues ends up having a snowball benefit effect on your patients. Thank you.